recording as well. So, hello everybody, thanks for joining us, and sorry for my clothes because I'm inside the university. Hello, Professor Lars, thank you very much for joining us. Fatima, please you remove your share at the moment. Thank you.
Oh, I'm
hello,
not sharing
Professor.
anything. The Fatima is not me, the other Fatima.
Yeah,
okay,
please.
I'm muting myself.
Thank you. Professor Lars, thank you very much. Thanks for joining us. That's a great
Hello.
pleasure. Hello. So you can
Hello.
start.
Okay, so thank you. First of all, I would like to hear if you can hear my voice, or is it delayed?
No, that's very good. We can hear you very well.
Perfect, perfect. I was actually, I'm not at office, you know, Sunday is off day in Denmark. So I am in my house at the land side, and I was excited to do this. I brought my computer, and I realized that my electric connection lead was at the office, so that's why my name is Vibe Root. At the moment it's my wife, and I got
okay.
her computer, so no stress. So once again, thank you for inviting me to this exciting event. And I don't know how you are doing this. I can understand that this is the fourth time, and some of you guys have been reading some stuff. And my plan is that I will perhaps let you discuss, and then I could share some slides with you during the session. I feel it's like we can make interactions and discuss, so it shouldn't be like a boring lecture like stuff when I do some slides, but there's a lot of stuff in that paper, and I think that what could be interesting is to have some clinical focus points and what might be some new ideas, and I think there's a lot of controversies about the deep lesion, and I think a lot of this, it is important to realize what do we have evidence behind and what do we think we think. So stuff like that, I think it's very important. Okay, so Dr. Nekufa, I suggest that you then run the
yes,
further progress of that. Okay.
Okay, first of all, again, I'm going to thank you again for accepting our invitation. That is a great pleasure to having a great name, Lars Brundal, with us. And I'm sorry for the pronunciation of your name. Can you?
And me too for yours.
No, you did that very well. You did that very well. I'm surprised. Thank you very much. But for your name, can you teach us how to pronounce your name? Because in many of our courses, we mention your name. Everybody knows you around the world. So you are a famous scientist, famous endodontist, and also you are a gentleman. More important than a scientist, you are a real gentleman, a good friend. So I want to pronounce your name correctly.
Thank you. No, it's just simply Lars Bjørndal.
Bjørndal. Okay, Professor Bjørndal, welcome. So for the information of our colleagues from around the world that join us, we are speaking from Tehran University of Medical Sciences. In Iran, we have a unique system that the medical sciences universities are different from the other comprehensive universities. So we have some dedicated universities to medical sciences, including medicine, dentistry, and other faculties. So therefore, our university is, in terms of the international activity, also is a pioneer university. So during the COVID-19 pandemic, we decided actually to run an online journal club, because what we used to have, that was a mutual journal club between Iranian university that was actually inside the capital, which is Tehran. And then we decided to expand it to other countries. So at the moment, we have received a very good support from Asian Pacific Endodontic Confederation, which is APEC. And we have the president of the APEC with us at the moment, Professor Mehmet Kayahan. As you can see, he is now showing himself. Hello, Bebra.
Hello, hello. I am coming from the dark.
Okay, yes, yes.
Good morning.
Your backlight is too much.
Yeah. I will adapt it later.
That's fine, no worries. As far as you are with us, thank you. So Professor Kayahan is the president of APEC, APEC, which is the confederation of more than 24 endodontic associations. So from the next month, this journal club will be under the name and the contract between Tehran University of Medical Sciences and APEC. So with the same situation, that means I have this honor to moderate the sessions, and we select a hot topic like the one that we have today. One of our resident postgraduate students today, the lucky one is Dr. Fatemeh Hamidzadeh. Fatemeh, can you wave to us? Fatemeh, say hello to everybody. I think your mic is not working, Fatemeh.
I want to say hello.
Okay, yeah, we can hear you now. So Fatemeh is going to present the article which is written by Professor Lars Brendal. I don't know again about my pronunciation. And then, as you know, Professor Lars, I'm going to speak, use your first name. Professor Lars is also the chief editor of a very important textbook that in our advertisement, I send it to you, a textbook of endodontology. That in this textbook, as you know, from Denmark, we have received this very special book, and I think it is the 4th edition at the moment in the market. Am I right, Lars? Is it the 4th edition? 5th, 3rd edition. And if you look at that book, you will understand why this book is different from other textbooks, because the background of that textbook is biology, is oral biology. And there are a lot of microbiology and biology in that book, so you can learn a lot about the evidence-based related to the biology and to endodontics, which is amazing. By the way, we are at the moment in the university, in school. We are seeing, as you know, in endodontic department, we see urgent patient as well. So with me, I have my postgraduate student around the table that you can see some of them as well. And on this side as well. So if you add us, we are 1, 2, 3, 4, 5, 6, and myself 7, to 132 people that join us. At the moment, we are almost 140 people from around the world listening to Lars and Fatemeh discussing about management of pulp exposure. We love pulp. We don't want actually to remove pulp. However, as endodontists, unfortunately, we resect the pulp tissue and we put it inside the bin. But Lars is going to teach us if we can save it or not. Thank you very much, Lars, to all of your effort and all of your scientific effort. We really appreciate that. And I'm happy to say that we have Hesam as well. Thank you very much, Hesam. I think Hesam also is connected to us from Denmark, if I'm correct. Am I correct, Hesam? Can you turn on your microphone? Dr. Mir Mohammadi Hesam is one of our Iranian friends that's living in European countries, and I'm sure is he in Denmark. Okay, Hesam, please say some greeting and we are going to start.
Hey, thanks, Dr. Nekufa, for everything. Good morning, because for us it's still morning. So I'm in the Netherlands, and I'm
you're
I'm
in
working
Netherlands.
at
Okay,
APEC.
yes.
Yeah.
Okay, good. We have a lot of people from India. Thank you very much. Hello, India. Thanks for joining us. A lot of people from Turkey. Thanks to Turkey also to joining us. Many people from Iran. I can see names from Canada, from UK, again from Iran, from different, oh, from Oman as well. Thank you very much, Fusion. Hi, thanks, all of you. I cannot actually mention all the names. By the way, today is a very important day and I don't want to waste your time. And I think now we have more than 150 participants. I play a little to receive all of our friends from around the world and make sure everybody is inside the room. Okay, Fatima, the stage is yours. If Lars wants to stop you, Lars, you can do that anytime. So if you want to stop Fatima, please feel free to do that. If any of our participants have any question, they can type their question. Lars can read them. I can read them for Lars as well. And we will ask Lars all of our questions. And if we don't like his article, we don't hesitate to tell him. We are going to criticize the author. That is a great day. Okay, Fatima, please go ahead.
First of all, I want to say hello to all of the colleagues and dear professors around the world. Today,
go ahead, we can hear you very well.
I want to present and discuss the review article with this topic, management of deep caries and the exposed pulp, which is published in the International Endodontic Journal. First, we have an introduction on caries as a disease. Caries is the most common non-communicable disease with a greater prevalence in patients from low social classes, actually. And it is very important that an average of about 5% of the overall health expenditure in industrialized and non-industrialized countries is spent on caries management every year. If you want to describe caries in the process of development of caries in simple words, we can say that we will have an enamel demineralization. Then the defensive reactions of pulp and dentin complex will occur. And if these procedures continue, we'll further have demineralization and actually cavitation in dentin. If you want to assess the depth of lesions clinically, it is very difficult and actually we can say it is impossible sometimes. But with radiographic evidence, we can make some terminologies. Deep carious lesion is a lesion which has reached the inner third or inner quarter of dentin, and it has a risk of pulp exposure actually. An extremely deep lesion is a lesion which penetrates the whole thickness of dentin, and it has the risk of pulp exposure in the process of our clinical assessment. And also, even we should emphasize on the fact that even in the initial lesions, we'll have the pulpal response just inside the pulp at the site of the lesion. And there is no need to expose the pulp just by the lesion to have these reactions. Here you see the two radiographs. The picture A shows us a deep carious lesion, and picture B is an extremely deep lesion, which I mentioned that it penetrates the whole thickness of the dentin according to radiographic evidence. Management of deep caries has been traditionally with complete caries removal. And when the pulp was exposed, the clinician usually decided to do root canal therapy. But today we try to have some minimally invasive approaches which are biologically based, and these approaches emphasize on selective caries removal and diet control actually, and their aim is to maintain the vitality of the pulp tissue. In cases of caries pulp exposure, the previous literature actually focused on the fact that these treatments that we usually call them vital pulp therapy, vital pulp treatments, they have poor prognosis according to previous literature. But by introduction of new biomaterials, techniques, and understanding of pulp repair mechanisms, the outcomes have improved, and we now see in the literature that pulp capping, partial pulpotomy, and full pulpotomy have satisfying outcomes.
Fatima, I think Lars is going to add something. Lars, please.
I just want to, I'm curious to know, you know, as an endodontist, we receive quite often patients where a lot of the story about how to avoid exposure somehow has been completed, and we are facing quite often in reality the act of removing the entire pulp tissue. How much are you involved in let's say starting the tooth from the very start in terms of caries removal procedures when you receive referrals, or are you let's say traditionally focusing on the teeth when we actually have gone beyond that stage of avoiding exposure? Because that's often you can say we can talk a lot about capping and stuff like that, but in reality, how often, besides university environments, how often do you as a specialist in private practice faces this issue? That was a long question.
No, that's a very good question. I think that for this question, I'm going to select some of the instructors from around the world to answer to that question first. First about that one, I'm going to tell you a quick answer myself from the Tehran University of Medical Sciences point of view. And then I'm going to ask Professor Meriç Kapandak to speak about that from the point of view of one of the schools in Turkey, and maybe one of our friends from other countries as well. So in Iran, and most of the schools in Iran, somehow I would say, unfortunately, we are very specialty based, and we don't have any integrated system. So what we have prosthodontic department, we have operative department, we have endodontic department. So that means in endodontic department, we don't have any vital pulp therapy cases a lot. And most of the cases that when they have caries, they refer to operative treatment for the operative department. And in operative dentistry department, obviously they try not to expose the pulp tissue at all. So they don't like actually to expose, and they prevent from that. That is for them. But if the exposure happen, and if they cannot control the exposure by doing direct pulp capping or indirect pulp capping or other capping technique, they refer to us, and then it is time for us to do the resectional treatment or non-vital root canal treatment. So if I want to answer you in one sentence, in endodontic treatment, unfortunately, we don't teach and we don't deal with vital pulp treatment. However, in some universities in Iran, some change happens. I know in some universities, they have a novel technique. You may hear the name of Professor Said Askari. He is actually one of the pioneers in Iran that developed, I would say, a very heroic system of vital pulp treatment, or even doing sometimes pulpotomy as the permanent treatment. So we criticize him for that purpose. I'm not going to discuss that at the moment. But in their university, I think we have Professor Zargar. So I may ask Professor Zargar to answer that question after Marriage. Marriage, can you tell us about your system in your university?
Sure. Thank you very much. Somehow we are lucky on that sense because we have a chance to see the patients all together. And so if we decide together with the operative dentistry and endodontics who is going to treat the case. And in case of referrals, direct referrals, we are lucky again because the deep caries is in many cases referred to the Department of Endodontics. So we receive such cases. In the undergraduate clinics, we are lucky again because we have an integrated multidisciplinary clinic. So I think it's a chance. We see many of them.
Okay, thank you very much. And may I ask Dr. Asadian Hadi also to open his mic and tell us what they do in their university. Hadi? Hadi, your microphone. Okay, okay, please go ahead.
Is my voice clear?
Yep, somehow, yeah, please. Yes, please.
I think I had some problems with my connection. It's just my connection is somehow unstable. I don't hear you clearly.
Okay, we can hear
actually,
you.
We treat the same way. We treat the cases as you do in Tehran University of Medical Sciences in different departments, in Department of Restorative Dentistry and Endodontics differently. Actually, student talks in restorative department is a scandal for the students. And therefore, vented and
Okay, Hadi, I think we cannot hear you very well. Sorry about that, but I think your connection is not very good. So I move to another colleagues from maybe India. One of our colleagues from India, please turn on your microphone and answer the question that Lars mentioned. Any of our colleagues from India can give us a quick comment about that? Okay, we don't, maybe I don't see, Professor Miglani, are you here? I can see Professor Pariroch from Kerman University. Professor Pariroch is one of our pioneers in terms of suggestion of MTA and other vital pulp therapy technique. Professor Pariroch, can you turn on your microphone and tell us your idea about the question that Lars raised? Okay, I think we already mentioned what happened in most of us, so integrated system and a specialty-based system. Lars, you can now give us your comment.
Well, even you can say in Denmark, where we have relatively few specialties, we are facing this problem. I mean, vital pulp therapy done by endodontists is primarily taking place at the universities. And one of my favorite topic is that sometimes it could be cool to look on this from the patient point of view. And if we should focusing on the best benefits of the patient, it may be nice if the various topics within dentistry somehow could collaborate and bringing like the patient safe from one paradigm to another, so to speak. But it's very difficult. It's very difficult, and we are facing that many general dental practitioners, with all respect, may do cappings, but maybe not in the way we would love them to do it. So on that basis, the vital pulp therapy has at the moment a very tough way to progress, and I don't know how to solve it, but I think it's important to say it out loud that we as endodontists are trained to, for many years, tradition for a much more complex treatment, but in reality, the pulp vitality therapy is also kind of complex, but it has always been like, okay, it's easy to do, but in fact, it may not be that easy. So it could be cool to change the culture, and well, maybe it should be more officially that the vital pulp therapy should be a specialist treatment, and in the view that the endodontist actually should do the caries removal as well. And that would be the difficult thing probably to change. But you know all that if you have the tooth from the start, you will really have the control of the stuff. But the reality, maybe in university environments you can do like that, but the reality out there is really a problem in terms of trying to do the best for the tooth when we speak about pulp, vital pulp therapy. And I just want to say that we know that, and then we can discuss the topic today. But we also know that maybe not that many that could have been received a vital pulp therapy receives it. It's much easier to get a pulpectomy. We know about that, and you know, if you don't do the vital pulp therapy in the right way, well, the patient gets pain. So it's not very popular to do it if you can't do it. So people may leave it. But let's have it in the back of our minds when we continue the seminar. Thank you.
Thank you very much indeed. I don't know, Professor Payrach, are you able to speak or not? If you're able, you can give us your comment while we are waiting for him. May I ask Professor Kayahan, what do you think, Professor Kayahan, about this?
And this is the reality. Sometimes some endodontists think that vital pulp therapy is the prophylaxis of the periapical bone, because when you do capping or vital pulp therapy like pulpotomy, you cannot follow the patient, and after then the teeth can be necrosed, the tooth can be necrosed, and it can defect the periapical bone. So with the rising of implantology, and probably it affects endodontics, and most of the endodontists think that vital pulp therapies are the prophylaxis of periapical bone rather than pulp capping. That's an interesting idea, but on site we can see this approach.
Lars, if I want to add something to that, that means maybe we are worried about the predictability and prognosis of vital pulp therapy comparing to root canal treatment. So if we want to make a crown, for example, if we do direct pulp capping, we are not confident enough to make a crown on it. So that is what I think Professor Kayahan trying to say. So what do you think?
Yeah, of course. You know, you may have read that paper. I myself have made a randomized clinical trials about capping, and with a terrible prognosis. I mean, after 5 years, less than 10%. And we may discuss that further. So I don't want to get into that more in deep. But what was realized on that results was that we need to improve the procedure. We call it class 2, yeah, if we really want to do the capping on a caries lesion. So I mean, it was a nice result in terms of saying, okay, we need to really think about if this is going to be something that makes sense. You also need to do it properly. proper, and people that know the stuff about controlling infection, well, then you have the key. But it was in a way somehow a little bit disappointing. I think it was around 30% after 1 year. We had success of the cappings, and maybe it was because we were treating pulps that were chronically inflamed, and then you have a critical cocktail when you expose and you may entrap chygenic fragments into the chronic pulp. Then you have a really critical cocktail, so to speak. But sorry for interrupting.
That's a very good important introduction. Thank you very much. Fatima, you carry on.
Here we are going to talk about the etiology of caries.
A bit louder, please. Louder.
There is a hypothesis called ecological plaque hypothesis. Is the sound quality okay? Dr. Nekufar?
It's okay. Sound is good.
There is a hypothesis called ecological plaque hypothesis, which emphasizes on the fact that whenever we have caries, an imbalance in the biofilm, the microflora biofilm on the tooth has occurred. And evidence shows that we have some species when we have caries, we have some special species that we have a strong positive correlation between the presence of them and the occurrence of caries. Also, in more advanced lesions, we have some other species which are not in normal biofilm of a tooth, which is healthy, and evidence has proved this fact. About the histopathology of caries within dentine, we know that enamel is a microporous solid, and the pulp and dentine form a complex or continuum. The initial pulpal response to caries is activated by the cell wall lipopolysaccharides of the bacteria, the acidogenic, the bacteria which are present in the caries lesion. Also, the metabolic products of the biofilm, and the acids which are produced by acidogenic and aciduric species present in the caries lesion. The demineralization is thought to be absent of bacteria as long as the dentin is not clinically exposed. Cavitated carious dentin lesion is just have because we have these species in the cavitated carious dentin, we will have a penetration of LPS, cell wall bacteria, through dentinal tubules, which is recognized by TLR4 receptors, toll-like receptors, and this will result in the pulpal reaction, the initiation of pulpal reaction, which results in inflammation, actually. And then we have a question: what is the defensive response of pulp to caries? The response of pulp is a combination of inflammation and the promotion of mineralization, and there would be a balance between these two events. Initially, as was mentioned, pathogen recognition by odontoblasts and later fibroblasts and stem cells and immune cells will result in the initiation of inflammation. And if the irritation of the pulp is mild, we'll have upregulation of existing odontoblast activity and the production of reactionary dentin. And if the stimuli is stronger, we'll have odontoblast death. And through recruitment of dental pulp progenitor cells, we'll have reparative dentin as a result. Other cells, such as fibroblasts or fibrocytes, may in fact produce the mineralized tissue, in spite of the fact that we think it is odontoblasts just which try to take part in production of mineralized tissue. And pulp exposure healing is it is occurred when we have the formation of a continuous hard tissue barrier over the exposure and a residual pulp free of inflammation. If we have these two events together, we say that pulp exposure healing has occurred. About the role of dentin in repair, evidence has demonstrated that breakdown of dentin matrix leads to production of dentin matrix components, which take part in the formation of this new hard tissue. I mean the repair of pulpal tissue, and it is occurred in combination with other bioactive molecules. These dentin matrix components, which are a result of the breakdown of the matrix of dentin, maybe some growth factors, chemokines, cytokines, and matrix metalloproteinases. All of these take part in some repair processes. For example, neurogenesis, angiogenesis, the mineralization, and recruitment of stem cells. And as you see, all of them will take part in the repair. About the clinical applicability of these components, we can say that when we use EDTA, hydraulic calcium silicate cements, calcium hydroxide, dental resins, ultrasonic agitation, and epigenetic modifying agents, they all try to sequester dentin matrix components and augment the regenerative response. There's some evidence that say sodium hypochlorite has a deleterious effect on stem cell survival and differentiation ability, and maybe because of that, in the revitalization procedures, the final rinse is better to be 17% EDTA solution. There is another fact that in vital pump therapy, although EDTA irrigation may stimulate repair through those components, but it may also stimulate bleeding, which is not favorable in the process we want to apply. Role of pulp cells in repair. Pulp cells will express some genes and proteins which will contribute to the mentioned processes I told in the previous slides.
Final destination yet, I think.
Okay, thank you very much. And there was also another question about the type of the tissue that will replace after the treatment. Is there any idea about or any consensus about this, the quality of the tissue and the type of tissue that replace after vital cover? I mean the hard tissue.
It's also a very interesting biological approach. Actually, right now, doing very exciting work. I think I don't know whether he's still around in the group, but Sune Demand, his specialist student from ACTA, we're doing a very interesting study on deep and extreme deep lesions, and I think on human teeth, and that's my key point. A lot of this has been examined on the basis of animal studies, and you can find like a pattern of the various tissues, but it's always a little bit different when you look in human teeth, and it's very complex. And I think the issue about the stem cells, we haven't a consensus on that. Where are they actually around? Are they in the cell-free, or are they actually everywhere? But what we can interpretate is the structural pattern of the tertiary dentin. And we do find a mixture in the very early stage of tertiary dentin. We do find like the primary odontoplast, let's say, having an ongoing production combined with kind of new beginners. You see the finger-like projections of what one in the old days could call secondary odontoplast, and that's mixed together. How that happens, we do not know. So it's not like we have a complete atubular border between the types. If the external injury is quite low, you can actually see that the tubular structure is running all the way, and perhaps it will be taken over by odontoplast-like cells. But if you really get rid of the odontoplast, you can discuss what type of cells will arrive, and of course, again, based on the structure of the tertiary dentin or the dental or the connective tissue matrix. Is it tubular or atubular? Then we can talk about the type of the cells. Going more deep into the biology, a lot of very interesting studies on the stem cell is currently running, but I don't think we have a final evidence of the origin of the cells producing the tertiary dentin. But of course, at a very late stage, one could speculate that we are away from the classical features of odontoplast-like cell. Thank you.
Okay, thank you very much indeed. There are some more questions that I raised them after we go a little further. Fatima, please.
Then we discuss current challenges to decision-making in deep caries management. We lack a device that can accurately establish the point at which the inflammatory process become irreversibly damaged and the necrosis ensues, and decide whether exposing the pulp is necessary or is best avoided, and can vital pulp therapy procedures provide predictable outcomes. In clinical practice, even when we have important subjective and objective data, it is asked from different dentists, and the studies have proved that there is not a consensus in the treatment approach that they try to use. Even when I emphasize on the fact that even when there is important subjective and objective data. Economic factors may also alter treatment decisions. For example, as remuneration for RCT in a molar tooth will be radically different to a vital pulp therapy procedure on the same tooth. We need next generation diagnostic devices to accurately determine the inflammatory state of the pulp. Still, it is something that we lack a device for it. Are endodontists the best candidates maintaining pulp vitality? There is some controversy because expertise on aseptic strategies fundamental to optimal maintenance of pulp vitality is something that endodontists are very good at. They usually use rubber dam isolation, which is very important to the vital pulp therapy procedures. But the nature of secondary care, in which endodontists mainly are involved, leads them usually to RCT instead of vital pulp therapy procedures. So we need clear guidelines both for treatment and for referral. Also, at the very least, increased education for practitioners in the optimum way to handle pulp tissues may be a good help. Treatment to avoid pulp exposure. Both complete caries removal and classic indirect pulp capping concept were invasive strategies, and there are some kinds of over-treatment. A 5-year follow-up of RCT showed that a stepwise excavation approach for the management of deep caries lesion was superior to a complete caries removal procedure, which was carried out in 1 visit, and this follow-up showed that less pulpal exposure, less pain and more teeth with vital pulps in the stepwise group. But there are still challenges. Residual caries dentin may shrink and potentially impair the coronal C, which may lead to some complications for pulpal tissue. And there is a lack of a permanent coronal seal during the less invasive caries removal strategies, which again may cause some pulpal and apical pathosis. And if the patient moves to a new dentist, it may appear that caries remains, and further intervention may be suggested by that dentist. Stepwise excavation in detail can be described as follows. It is carried out in 2 visits. The aim is...
Fatima, can I stop you again? Lars, please, go ahead.
I just want to stress the interesting point about the shrinkage of the caries dentin, and in reality that concern, because you know we may have reached a good consensus about the stepwise excavation approach, and now communities are trying to ask, is the final second visit actually necessary? And one excuse me, one point I just wanted to add is that the shrinkage element would be the point one could have concern about if you do not carry out the second visit. And you may end up saying it, sorry, but I just also want to say that in terms of evidence, I think we are still not there talking about in apples leaving caries tissue behind in the deep lesion. We still need work to do, and we're actually carrying a big multi-center trial, even including friends from India working on this topic. But it's important when you mention it in relation to the stepwise excavation. I may have taken it for wrong, but the shrinkage phenomena is what we actually take care of when we do the second visit. Normally one could ask, what do I do here when I arrive? It looks very arrested, but in reality, you may find a gap between the filling and the tissue left behind, and on the long run, that could mean a problem with the restoration. So one of the points doing the second, it may not matter. That is what we are going to investigate. But it may also be a relevant point that we are optimizing the final cavity for the restoration because we are removing the arrested. There's nothing wrong with the arrested tissue perhaps, but it has shrinked, and the cavity has perhaps a less optimal interrelation, and therefore we want to actually end up having a permanent restoration on a cavity that do not change. And that cause of the second visit might not have been highlighted that much because people have been focusing on removing the tissue left behind, but in reality, we want to optimize the cavity. Thank you.
Okay, Lars, there's two more questions, and then I'm going to ask two of our colleagues also to add comment to that. First, about the markers for the diagnosis, and the second one is about the use of MRI for the diagnosis of the vitality of the pulp tissue and also the quality of the formed tissue or replaced tissue. What do you think about that? The markers, cell markers or molecular markers, and also use of MRI.
So the non-invasive measurements of inflammation, is that the question?
Yeah. Yep.
That we
the question is just the first question is about the use of magnetic resonance imaging, MRI, for evaluating the pulp status after doing the vital pulp therapy anytime. Do you think is it relevant?
I have to also sometimes say that I will not be the correct person to answer that. So it will be. I have to say that the level of background behind that, I don't feel I can answer that.
Okay. And what? I'm going to ask first. I'm going to ask Dr. Parirot to add something, and then Dr. Kumars, because Kumars also sent a lot of good comments in the chat room. So first, I'm going to ask Dr. Parirot because Dr. Parirot, Masoud, are you ready? Yeah. Okay, Kumars, you go ahead and then, okay, Masoud is ready. Masoud, please share your slide. Fatima, if you unshare your slides, then Masoud is able to. So while Masoud is trying to share his slide with us, I'm going to quickly introduce Masoud Parirot to you. Masoud Parirot is one of the pioneer endodontists in Iran. And as many of you know him, he published a lot of articles, and one of his articles is mostly cited articles about MTA, is one of the very hot topics, and we are very proud to have him between us. And he is actually one of the very, very good scientists in Iran. So Masoud, please go ahead.
Thank you very much. First of all, let me thank you for this very good journal club that everyone will enjoy it, I am sure. The slide that you can see here is one of my experiences in ANU, Australian National University, in 2003. We did pulp capping for dogs, and you can see the result here. In the left side, you can see crystals of MTA after setting, and the right side, you can see globular structures, which are the structures formed by dental pulp of dogs following pulp capping. And I would like to say this is the structure we see mostly in H&E staining by light microscopy, but here in SEM, we took some pictures from the side, and you can see the globular structure would give some way to future leakage and microorganisms that could penetrate into dental pulp. And for that reason, it's very important to have a very good coronal seal in order to prevent that leakage. And it's very important because at first, when pulp come into contact with MTA or some other bioactive endodontic cements, the pulp would form some structures that very easily could penetrate by bacteria. But then when some hard structures form, then pulp could provide some more tubular mature structures. in this slide, I took SEM in 5,000s power, as you can see here, and another slide here, which also taken in 1,000 power. You can see here a few tubular structures in comparison with calcosphorates, with highly tubular, which is a mature previously formed dentine, and here with lower number of tubule, you can see the structures formed following pulp capping by dental pulps. And this is the difference between the newly formed hard tissue structures and mature previously formed structures. That is regarding the question you asked before about the difference between structures of newly formed hard tissues and previously formed hard tissues.
Thank you. Thank you very much, Masood. Kumars, okay, Lars, please.
So so now we are talking about hard tissue building after capping, correct? After capping, yeah?
Yep.
Yes. I always think about the French guy from the 1980 that made a quite nice, huge monograph about the pulp, Boom, Louis Boom, talking about fibrodentin. What is your opinion about fibrodentin as like the first step, and then on top, actually you can say that fibrodentin in his wording was the first part of reparative dentin, and then on top of that, have you ever seen then the tubular structure starting like you know, Chiafas want to show the reparative dentin starting with a tubular dentin, and then on top of that you have tubular dentin. What have you seen in relation to the capping hard tissue? Will it end with a tubular structure, or is it mainly atubular all the way?
Okay, it depends on when we did sacrifice the dogs and after how long we did our experiments. You know, for example, I would like to show this image. This is the one that we took about 2 weeks after pulp capping. Here you can see after 2 weeks we have a calcified bridge. This is MTA, and here you can see dental pulp beneath the calcified bridge, and it's very important because, you know, in which period after pulp capping we see the dentin or the calcified tissue beneath the capping materials. Then you can name it different names, as you mentioned Riccocci in 2014. Say something about calcified bridge formation beneath the dental pulp, and the very strong article he published with his colleagues. And it's very important to I guess the name is not important because it depends on the time that we have following pulp capping. And the important point is at the first time we have unmature, very, as you can see here, a structure with so many tissues surrounded by calcified tissue. The cells rapidly form calcified bridge, and for that reason some of them may surrounded by those calcified bridge, and for that reason we have a non-tubular calcified bridge. But then after some hard tissue formed beneath the capping material, then dental pulp could easily form a calcified bridge with mature tubular-like structures. And for that reason, we cannot call odontoblasts here. We call them odontoblast-like cells, which are the cells that provided by fibroblasts or macrophages and other cells that you know better than I. And I guess, for example, if someone see the calcified bridge here may know something, but later they may see this calcified bridge, which is more mature compared to the previous one, then they can say something else. They name it something else. And for this one, for example, you can see here a calcified bridge in here is more mature than the calcified bridge here with very the structure which is not very unique.
Good point.
And there is also a question about the difference between the quality of the hard tissue when we do direct pulp capping comparing to indirect pulp capping.
Sure.
Lars or Masood, any of you, please go ahead.
Well, I think that we have just heard very nicely the pattern where we have a direct exposure, a tubular matrix is the starting point, and in relation to indirect or where you do not make a capping, I think it will be an ongoing process of the tertiary dentin, and it most probably would be, as Rikuchi indicates in the 2014 paper, that it may end up being a tubular structure, but if you do change the environment, as you would do if you do less invasive excavation procedures, it may be like you end up as in a dentin bridge formation, that the physiological conditions within the pulp would, let's say, signal and do the possibility of a new tubular structures. But not that many studies actually is around talking about what has been taking place following indirect cap in humans. So it's a very good question, but you could speculate as I've been doing now.
Okay, thank you. Kumars, go ahead, please.
Hello to everyone. I am honored to be participating in your conference that you held by Dr. Nekufad, and I said that MRI is not a suitable tools or device for evaluation of the form tissue inside the pulp because we have the hard tissue. For evaluation, the routine radiograph of periapical, also CBCT is suitable. And it's important to know that if symptoms of the pain lingering after the cold or hard stimulus, it is possible for us to respect to the pulp tissue. And I believe that the pulp tissue is a saint and we should respect to it. Even the sensitivity to the percussion or lingering or spontaneous pain, it doesn't mean that we can't preserve the routine that exists in the root canal. It means we have, with a coronal pulpectomy, it's possible for us to preserve the remaining pulp that existed in the root canal. Thank you very much.
Okay, thank you very much. And there is also another question related to that, because the question is about the apical breakdown. So pre-apical breakdown. So Rikuchi believed that even when we have pre-apical breakdown that is diagnosable in, for example, CBCT, still we can do vital pulp therapy. However, on the other hand, many people believe that when we have pre-apical breakdown, we shouldn't do vital pulp therapy. This is the question. What do you think about that?
I think it's possible for us, even when we have a periapical lesion, by using, as you know, the periapical has many paucity and deficits, such as in 40%, the periapical lesion existed and the radiator did not show it. So even in a tooth with reversible pulpitis, even in a tooth with periapical lesion, it is possible to preserve. We can do it. As you know, the new material were published in IEG. It's shown in mature tooth, we can over-instrument it and let go to stem cell inside the root canal and show about 90% success. It means in mature tooth, it is possible for us to use different kind of the regulations method and procedure. Also, if we have a periapical lesion, it's possible for us to do it.
Lars, what do you think? Do you think if we have a periapical breakdown that is diagnosable on CBCT, can we do vital pulp treatment? And obviously, if it is not on the CBCT and on the periapical, because QMARs believe that even if it is on the periapical radiographs, we still can do vital pulp treatment. What do you think about that?
Well, it's always a little bit difficult to interpret the black hole, isn't it, on the CBCT? What is it? But it was interesting, of course, the group from UK doing these findings that we may be able to pre-diagnose inflammation and at a stage where the infection has not reached point of no return, in fact, maybe even no infection at all. So it's interesting, but I also think there's some problems in the interpretation of the black holes, if we could call them that, on the CBCT. Actually, we have had some nice research in our neighbor university in Denmark, Kruse, together with Kirkevang, have examined cadavers and used CBCT, and it's not always straightforward what you find behind these initial changes on the CBCT. But the clinical findings from this study showing lesions before the classical X-ray is very interesting, and they also could support it by their clinical findings. So it's very interesting, but it may be an expensive way to determine the status of the pulp if you want to expose it within the general practice environment, if we should put it one step further. But as a research topic, I think it was very interesting.
Okay, thank you very much. Yep, please, but do it quickly because of the time.
Okay. Dr. Turabnejad presented about, I think about 20 years ago, a case from the Japan. It's anterior teeth with periapical lesion, pulpitized and then covering with MTA, and then followed for 6 months. The periapical lesion resolved totally without any manipulation inside the canal or adding other material inside. It shows that even adding material at the orifice of the canal, it is possible to change the pH at the apical, as many other articles shows when we use calcium hydroxide.
Lars, anything that you want to add, or can we carry on with Fatima?
Excuse me, can I add something?
Okay, let us carry on a little with Fatima. What am I thinking to say is, I think because of the time, because we said 90 minutes for this donor club, so we just have something like 12 minutes from now. And definitely we cannot finish the article. While we are here, I want to ask Lars, if possible, to carry on this maybe in 2 weeks' time, if you're okay, and if it is okay for you to come back again to this online journal club and finish the article in the next 2 weeks. Is that okay for you, Lars, to join us again? Or maybe next week? Okay, so your microphone is off, White, please. Okay, yes,
Well,
we can hear you.
That will be the 8th of July, or what are you talking about?
Let me check. Yes, 8th of July. So next week, today is 14th of June. No, that is the 28th of June. In 2 weeks, it is 28th of June. Am I right? Yes, 28th of June. Is that okay for you?
Yeah, Sunday, yeah.
Okay, good. So we carry on for 11 minutes because we actually promised everyone to be very punctual. So we start on time and we should finish on time as well. So we will finish in 10 minutes, and we will see each other in 2 weeks. Okay, Fatima, you carry on for another 5 minutes because we want to have another 5 minutes question as well. Thank you very much, everybody.
The process of step-wise excavation in detail is as described. It is carried out in 2 visits. The aim of the first stage is to change the karyogenic environment. Selective caries dentin removal to soft dentin is performed. And the second stage excavations will be held several months later. And a calcium hydroxide based material or a hydraulic calcium silicate cement between visits will be applied, and the teeth are restored with a glass ionomer restorative material. Physiological response to the capping is as described. Formation of a reparative dentin by odontoblast-like cells is possible after pulp exposure. Many non-mineralized defects called tunnel defects can be seen under the microscope, and they may be a source of invasion of microorganisms. And maybe that is why we should have a very good coronal seal and a good restoration. Pulpal inflammation and in situ diagnosis. Maybe we need further clinical studies to investigate molecular-based assays for diagnosis. Practitioners must make do with the existing methods of detailed history and pulp sensibility tests. Other options include assessing the level of pulp hemostasis as inflammation is associated with hypervascularization. Practically, the exposed pulp is packed with a damp cotton wool pellet, and pressure is applied for at least 5 minutes. And this should be enough time to achieve hemostasis under physiological conditions. Then we'll have a dry working field. And if the bleeding persists, it may be assumed that some of the pulp tissue is still inflamed, and further pulpal removal is necessary till we reach the healthy tissue. As it was mentioned, we should try to reach this hemostasis and disinfection. And it is done through visual analysis. Actually, it is not sufficiently accurate, but it is done in the clinic through visual analysis. Control of bleeding and avoidance of blood clot formation between capping material and the pulp tissue is necessary because the presence of blood clot has been linked to higher risk of postoperative infection. It was shown that the various approaches did not affect the expression of bioactive glycoproteins related to repair. there is a review on studies who just try to see if sodium hypochlorite is a good disinfectant in these cases. A disinfection agent such as sodium hypochlorite is applied prior to application of capping material to have a disinfected environment in the cavity. Sodium hypochlorite is generally the disinfectant of choice, but has drawbacks as it is corrosive due to its organic tissue dissolution ability. And it interacts with dentin, interfering with subsequent bonding processes because of collagen collapse. And because of that, there are some evidence that say chlorhexidine is preferred for disinfection in these cases. Pod capping classification. Here we have the pod capping.
Fatima, can I stop you, please? Thank you very much, because there are two more questions. I think this is a good place that we stop. So we stop at pod capping classification for the next journal club, which is in 2 weeks. And there are two questions actually that we can go ahead for that. First, I can see Mr. or Mrs. Chandra Sekaran. Chandra Sekaran, can you hear me? And because you raise your hand and you want to speak. And then we have Fatime Betul Bashturk. Fatime, please go ahead, ask your question while we are waiting for Chandra to turn on your mic, turn his microphone. Fatime Betul Bashturk, please go ahead.
Okay, thank you very much for the very enlightening lecture, actually. I had the privilege to attend ESE's conference, actually panel on vital pulp treatment about 2 years ago in Amsterdam. And I had the privilege to listen to Professor Bjorndal himself. There were some debates about the agents to use for controlling the bleeding. So I want to ask, on a clinical basis, what Professor Bjorndal would prefer to use while doing the controlling of bleeding. Would you use, I mean, sodium hypochlorite or chlorhexidine or distilled water or just simply cotton pellet?
Thank you very much for the question. Also, there is a question related to the blood clots. That's why we shouldn't have blood clot underneath of the material. And also there is another question from Professor Kayahan about the sodium hypochlorite and also the best material to control the bleeding with that. Lars, please go ahead.
Okay, thank you. First of all, I have to say that I'm very much inspired of the work and protocol that was made by George Boken. And I think he was perhaps one of the first that did the treatment using magnification and that pushed the disinfection strategy from saline to an actual disinfection. And based on the fact that we have evidence, observational evidence, not randomized evidence, but based on the fact that that protocol has proven that it works, I still would use sodium hypochlorite. I know now that he has increased the concentration to, I think, 10%, but I will stick to the one that was published back in I think, was it 2008 or something like that. In terms of the clot, it's very interesting because we have a lot of interesting, in fact, bioactive molecules in the blood clot, but we also know that the blood clot is very keen to take up bacteria. And I think it was Schröder from Sweden in the mid 80s that actually had the point that we should really take care of not leaving a blood clot beyond the restoration because, or the capping material, because we then raise the risk of getting a contamination. But of course now we know that there's a lot of interesting bioactives things in the blood clot. So it's not because per se the blood clot is a problem. It's about whether we can control that it gets infection, a higher risk of infection, I think.
Okay, thank you very much. And Chandra, please turn on your microphone. Chandra, you want to ask your question? Please go ahead. Okay, I think that's it. So at the moment, we are going to have to finish our online journal club in 1 minute. Thanks again to Professor Lars for his contribution. That is amazing. I know this is Sunday and you should be with your family. Please send our greeting to your family and our apology to them. And thank you very much for being with us. And we are very proud to have you in Tehran with us. Yes, please, Tehran.
I'm honored to get the invitation. So we will see each other in 2 weeks.
Yes, and I'm going to ask everyone to turn on their microphone and put their hands together and start clapping for Lars. Thank you very much, Lars. Thank you very much. Thank you, and see you in 2 weeks. Goodbye, everybody, and see you in 2 weeks.
Bye-bye.